talking about mice.
Yeah, I was a bit worried about that, actually.
It is the board meeting, I assure you.
All right, just wait for Julian, I think, is it? Julian, I think we're all here now, aren't we? I think. Oh, Rajiv's still. Oh, Rajiv's there. No, we're all right. Okay. Okay, well, good morning, everyone. Yeah, Rajiv, you're on twice. Is it? It doesn't matter.
Yeah.
Don't worry. Don't worry. Well, morning, everyone. Welcome to this public board meeting. Any questions from the public, Julie?
No questions and no apologies.
Okay, that's good. Declarations of any other business? Declarations of interest? Minutes of the meeting of the 14th of January. Any corrections, please? No. Okay. Action log and matters arising, as far as I can see, are all in hand or done. So unless anyone wants to raise anything. Okay. So quality section, item 6. Board story, pediatric ADHD. And Debbie, we have Michelle here. Debbie, going to introduce it?
I will do, yes. Michelle's kindly come along to talk about a complaint that we received into the service and the response and changes that have been made as a result. So it's slightly different today. So I'm going to hand over to Michelle, who will take us through her presentation.
Welcome, Michelle. Over to you.
Thank you. Thank you. Good morning, everybody. Just make sure I can get this to work in Teams. The normal, isn't it?
Don't ask me.
It's always a
we
problem.
Can see it.
Brilliant, thank you. There's always a problem, isn't there, sometimes when you're presenting teams. Yeah. So yeah, I'm the team lead for the ADHD team, so the Children and Young People's ADHD team. And we received a complaint from the parent of a 16-year-old young person who was referred for an ADHD assessment from their school due to concerns about poor focus and concentration. The complaint was related to the initial appointment, and this young person also has an autism diagnosis, and the complaint was around the processes and the environment and the parent was very adamant that it wasn't around clinicians or the care they received. It was more about the processes we have in place and the environment. So I've just done an overview of what the parent was saying, that the waiting room at first, I don't know if people know Furtree House at all, but it's a very old building, and felt it wasn't neurodevelopment friendly. The decoration was poor, the walls were too bright, the lights were too bright, the chairs were uncomfortable. And he did feedback suggestions about how we could improve on the environment, and also complained about the receptionist was hidden behind a glass screen. Sorry, somebody said they can't see it. Is everybody else able to see the presentation?
I can see it.
Okay, so I'll briefly sign out and sign back in then. Sorry, I'll only be a couple of seconds. Sorry, sorry to interrupt.
That's all right. No, it's fine. It's not great when you can't see it, is it? Really? So it was more of the overview of what the parent was concerned about. So it was, again, as I said, it was all about processes and the environment around it all. So I was made the investigating officer. I did my initial response about it all. The father was unhappy with the initial response and asked for the complaint to be reopened. So I did another investigation. So we did take a lot of actions into consideration. So we have now got a quiet waiting area introduced at Furtree House, so that people who are neurodivergent or just want a bit of a quiet space can actually have that. The reception staff do tell the families now we have that, and actually that was instigated the day after the very first appointment for this family. What we didn't wait for the complaint to come in, we instigated this straight away. We also suggestions about how we improve it. We have done a lot of work, and actually I was there 2 weeks ago, and Furtree House has been repainted. It's looking very, very nice, actually. It's all bright and colourful. It's not grey and green. It's really bright now. I walked around the whole building. It's looking much, much better, actually. We all spoke about not having suitable rooms available for neurodivergent children, so we've now put a booking system in place so that we've got it, so the clinician can alert admin to know what's the right suitable space so they can get a suitable room, so it's near the entrance or further away. We've also can take them in other doors if they don't want to walk through a busy waiting room as well. We have also changed our letters so it's much more clearer for families and young people to know who the point of contact is for any future appointments. We work very differently from lots of teams. We have a central team that deal with up to assessment, and then it goes into locality. And that wasn't clear on our letters, but it's much clearer now. So we have made changes on that. We also emphasised we've done a lot of work with staff about communicating more effectively with patients if the rooms are clinicians are overrunning in rooms that are booked. So that's been reiterated with all staff, and we talk about it in our huddles every single week. So we have put a lot of stuff in place. There was a lot of stuff missing from Rio, so we have put processes in place, a checklist in place, so nothing's missing in Rio. There was a lot of admin missing stuff, so that's all been implemented, and we monitor that to make sure it's still happening. Look, there was a problem. The parent said about voicemails. I've done a lot of work with the locality admin, ensuring that it's very clear on the voicemail system how long it will take for them to respond if they can't get an answer. It's now been put onto the voicemail system as well, that they will get a reply within 24 hours, not within a couple of hours. We also did a lot of work, I've worked with a lot, people know Fir Tree House, there's a lot of services work out of Fir Tree House, so I had to work with multiple teams within Fir Tree House to make sure we're all working the same. There was a lot of people were chatting in corridors. We've made sure that through the managers and team leads of other teams that these discussions are not happening in corridors or waiting areas. So I've worked really extensively with lots of other teams within Fir Tree House as well. So there's been an awful lot of work, and it's still ongoing. So we're still monitoring what's going on in localities, what's happening with the teams in other localities. I contact the team leads to make sure that everything's still in place, nothing's changed, that we're still monitoring everything. The learning has been shared within the ADHD team, but it's also been shared within CIPIT teams as well, and with paediatric teams too. So after extensive piece of work, we also took into consideration this young person's neurodiversity. So we offered online appointments for the young person going forward if they found it very difficult to come into the clinic rooms. So we've continued to be very flexible about how we offer appointments, especially, but not just to this young person, but especially to this young person and the parent. And this young person moved out of area to a residential school, and we continued to meet with them online for their ongoing appointments. And I just wanted to say that after this, we investigated for the reopen complaint. We did receive a thank you from this parent saying that he was very pleased that we'd read his in full, we'd done a comprehensive response, and that we'd taken action and improved things in regards to what he'd complained about.
Very good, Michelle. Thank you very much. If you could unshare, could you?
Yep, will do. It just takes a while for me to find my mouse.
Don't worry, don't worry.
That's not coming out. Just bear with me. It's not coming out. Oh, it's just not. That's not happening. Sorry.
Okay, we'll just leave
technology.
We'll take the questions. I think Mark Day first.
Yes, Michelle, thanks ever so much for that presentation. It's really encouraging to hear when we get feedback that so many fairly comprehensive list of actions and improvements have been made. The one thing that caught my attention, though. You said that initially the complainant was not happy with the response from your initial investigation and asked for it to be reopened. Can I just ask, what was that first response and what happened initially to have to prompt them to come back to us a second time?
Yeah, so he added some more points, and we hadn't gone into detail about all the actions we'd put in place already. So he wanted it more in depth about what actions we were doing and how we were monitoring it all. So we did more of, so the first complaint was more generalised. So we actually put the action plan into it, that what we were doing and how we were monitoring it and what we're still looking at doing.
So it was a case of more things being added by the complainant rather than an inadequate response to the first one. Okay, no, thank you.
And we actually, I hadn't put the action plan in the first one. I had alluded to it, if you like, but not went into detail. So I went into more detail about what the actions we'd actually done.
That's great. Thank you.
Michelle, are you able to unshare? Because
oh, I thought I'd done it. Sorry.
That's better. Thank you very much.
That's all right. I thought I'd pressed the button. I must have missed it. Sorry.
Okay. Alex.
Michelle, thanks very much, and great to see the effective response and feedback from the complainant, that they're satisfied. I can see from your background you've been supporting our neurodiversity strategy and you're directly connected to neurodivergent patients and of course our staff as well. And I can see from the presentation you've shared learning with the ADHD team for a kind of wider learning and change that we could implement. Are we feeding more broadly into our neurodiversity strategy? Because the environmental issues that you've raised are really important and I expect exist elsewhere in the trust where we're supporting neurodivergent patients and clients.
So I have been liaising with Mary Evans around it all as well.
Great.
So yes.
Thank you.
Okay, thanks so much, Alex. Sally.
Thank you very much, Michelle. It might be a bit of a left field question, but this young man was 16. So, you know, he's 17 now, and then he'll be transitioning to adult services. And I just wondered, I think you shared it with the adult services, but whether it raises questions, because actually up to now we haven't, well, perhaps it's just me and I'm not being aware of it, but the transitional pathway from children's services to adult services around ADHD and neurodivergency hasn't been quite so developed. Am I right in assuming that, or are we have we now sort of, is it now, this sort of complaint raise, and the age of the young man raised issues around, well, are there any things that we could make this smoother as he sort of gets to 17, 18 and then on to adult services?
We work very closely with our adult colleagues. My manager also manages the adult team as well. So we work very closely with the adult team. We've done a lot of work on transition with the adult team. We've made booklets up and everything for that transition. So we do have a really good transition programme into adult services from our service.
Right. No, that's very gives some assurance around that. Thank you very much.
No problem.
Thank you. Naomi.
Thanks, Michelle. Really good presentation, and I was struck by, in particular, the principle of listening to our patients and carers, and co-producing, coming up with solutions that listen hard to what our service users kind of expect of us, and developing improvements and solutions on that basis. So that's really good. On the other hand, I also have to ask the question about, why in some ways did we have to wait for a complaint for us to respond? And I know that sounds harsh, and that's not my intention. But quite rightly, we live in a world where we would always want to get ahead of those things rather than waiting for something to emerge that we then have to, we're slightly on the back foot. Any thoughts about that?
I think sometimes when you're doing it day to day, you don't realise what's missing off things until somebody points that out to you. I think we've been using letters. if you miss things quite a lot if you're not on the receiving end of it, really. So sometimes I think we don't always get it right, and we need to listen to what people are telling us so we do get it right for them.
Yeah, so
It's quite
there's those blind spots
there is blind spots sometimes. Yeah, and I think it's quite hard with I don't know if people know Furtree House. It's not the most exciting of buildings to be in, but is a lot of work. We've managed to work with a project team to get some additional funding to make the building much better for us.
And that's an interesting point right there, because that sort of prompts another thought that I was having around, and actually picking up on what you were saying, Alex, around looking at this slightly more strategically in terms of our neurodiverse patient group. So the question arises: is Furtree House the right place for ADHD and autism? Are we, given that the number of services for children that we treat in that particular asset, are we asking too much of it? And should we be thinking a bit more strategically about where our neurodiverse patients are actually seen? And maybe that, Michelle, is a question a bit more for the executive. Any thoughts, Alex or others?
Yeah, I think it builds on the points that we're making. We need to take a review how we're looking after our diverse patients and staff, and we need to have a look across the estates. And so I will be going back to Mary Evans, who's leading on our neurodiversity strategy, just to check in, and with Martin Mannix, our estates colleague, how we're doing this link up.
And I just come as well. So I know Martin's been working really closely with the 3 divisions around developing an estates strategy. And I guess with everything as we go into the next year and the year after, we just need to be really thoughtful about how we manage some of our competing challenges. So we have some of our estate, which it's not good for any patients. I think we would acknowledge that. And we're doing a lot of work around how we exit buildings that we might not want to be delivering care in going forward, but then also how we really improve the buildings where we do want to stay, so we can really invest in those. And what the divisions are starting to do, which is really positive, is to think strategically across a number of different services that might be occupying the same building to see how they might use them differently. Quite a slightly different way of working, I think, but it's sort of partly the next iteration of having reconfigured our operational divisions so that they understand that we're all kind of working together to deliver services across Berkshire. Now, some of that's easier than other in some of the estate that we have, but I think particularly picking up on your point, Alex, as we go forward, as we're sort of developing buildings, as we're improving it, making sure that we take that the experience of both our patients and our staff into account, so that we're really thoughtful about if we're redoing awaiting areas or anything else we can do to make it a more appropriate experience for anyone who might be using it. Can we be a bit more flexible about where we're running clinics, for example, maybe taking some patients into a quieter area or a quieter space or a quieter building? So I think it's a good point for us to kind of be building into the next iteration of the strategy.
And I just want to say, we have, since this, we've looked at all the buildings we use, and we're looking for quiet spaces for them now. So we have been, not just in Furtree House, we have been looking at all the areas we work out of now.
Okay, Michelle, thank you. Samina, I should have just introduced you that you're from the ICB and you're sort of observing, but I think you've got your hand up. So do you want to?
Are you happy? It's an observation to say, well done, Michelle and team, for really acting on it. I'm on the Mirror board. I work for Children and Young People's Transformation Lead for Mental Health and SEND. And I think it's right. We're so ingrained in business as usual. We don't always lift our head to see what else we can do as improvements. I think I'm really pleased that the father persisted and asked for the complaint to be reopened, and that you honoured that and looked at it again. I think estates is always a challenge, but I know for Slough, Upton Hospital, yes, it's an old building, but it's very valued by the residents of Slough, and it is monumental and a lifesaver for those children that are, ADHD and neurodiverse. So, I think, no, well done. I'm only here until 11, but when I heard when you were going through your presentation, I was like, wow, that's transformational. So yeah, thank you.
Thank you, Samina. Paul.
Yeah, it was just a quick point on the estate and making it fit for neurodiverse. I think Martin's been keen as well to pull in partners from our PFI providers and from NHSPS as well, obviously recognising they provide a lot of our estate. I know we've taken them with various visits and conferences to look at how we can improve the estate. So I think it's important we bring our partners along that journey with us.
Thank you very much, Paul. Julian.
Yeah, it's a really good conversation, actually. Well done, Michelle. Thank you for you and your team. In some ways, to go to Naomi's sort of point, there's a few things that the sort of board, I suppose, have got to now wrestle with, and that next iteration of the estates plan will be sort of key to this. So to some extent, you know, if you make most the waiting rooms suitable for neurodiverse people, then they should be suitable for everybody. The only issue that's challenging is the quietness. And so as a board, if we're saying we'll also find an additional quiet space, we've got to also think, okay, what does that look like in terms of estates utilisation, productivity, that kind of thing. And I guess the other thing is that if we take the Upton estate, we prioritise quite rightly the patient safety issue of Jubilee Ward in terms of capital spend. I think that was the right thing to do. So with our budget, which we know is likely to be about £8 to £9 million a year, we need to look at how we can best utilise that kind of budget in order to kind of make these improvements. But I think we can, as Michelle has shown, make some quite simple, not particularly costly improvements to some of our areas, which shouldn't be beyond that. I think probably the challenge of creating separate quiet areas is probably the kind of bigger challenge, in terms of is there actual physical space, and second, utilisation of space. And I think it'll be quite a useful theme to look at when we next see the estate strategy, Martin, how the kind of trade-offs between the various priorities, really.
Yeah, I agree with that. The comment opposite. Well, thank you, Michelle. It's great. Great to hear. I was just wondering whether online. I didn't want to start a new discussion, but you mentioned online as being, you know, possible for these sorts of patients who have concerns about noise, etc. They might well feel, I think you indicated, you know, quite comfortable online as opposed to physically meeting, and whether, you know, having a clarity about how that's managed and perhaps expanding that option for parents and children who find it easier than going into a noisy place, however well managed. I don't know. It's
so we do offer quite a lot of online appointments as well. So we have now put stuff in place that we contact families asking what they prefer.
Okay. Right. So it's an option that's being sort of properly explored, as it were.
Problem is with the ADHD team, we do need to do physical observations on children, so we do need to see them as well. But we've worked out that we can see one appointment online and then the next in person. So we negotiate it with the families, but we do offer both to all the families. But we do need to see children in person to do physical observations on them as well.
Very, very good. In which case, Michelle, I think time is against us now, but thank you very much.
No
Great
problem.
work.
Thank you very much.
Thank you for an excellent presentation. Bye-bye.
Bye-bye.
Okay. I thought that was very interesting. Can we move on to patient experience quarterly report, Debbie?
Yeah, this is our usual standard quarterly report. Just a couple of things that I would pull out. We have seen a decrease in formal complaints and an increase in complaints that are able to be resolved informally and locally, which I think is really positive, because that means teams are taking ownership of concerns and addressing them, nipping them in the bud before a formal complaint is needed. We have continued to see an increase in our numbers of patients completing feedback, which is really good. You will see that there's been a decrease in the percentage for this quarter, and that's because we have had a significant, around 200,000 significant number of school age seasonal immunisations, and the chance of a child who is nipping into a gym in a primary school getting their immunisation and going out again completing a 10-question I want great care feedback is pretty much nil. But we are continuing. I've just looked at February's actually, and we are continuing. We've actually hit 7% for February, so, and virtually 4,000 feedback. So we are continuing to go in that upward trajectory, which is a result of services still having this as part of their huddles and their active looking and reviewing at how they actually implement and take this forward as breakthrough objectives and driver metrics, which is brilliant. That I've added in this time, I talked briefly last time in Q2, we were able to add demographic filters into the dashboard. I've just in this highlight report given a bit of an example of some of the things that we can pull out. It is a tiny snapshot. We can do loads with the data, and I could have probably written you a huge document about all that it shows, but it's brilliant for services when we're looking from a equality, diversity perspective to be able to cut the data and look at it through various demographics. And other than that, I'm happy to take any questions.
Thank you, Debbie. Sally.
Debbie, the decline in the issue around continuity of care and smooth transition, when you delve into the detail, is that around a particular area? I know, for example, mental health patients, they often complain about having to tell their story repeatedly to different psychiatrists, but is that an issue which we've got in a particular part of the trust, or is it generalized? And secondly, do we know, have we been able to sort of delve into that and see what's behind it essentially?
There's generally mental health patients, absolutely. I haven't looked when I did that demographic data, I haven't looked more detail in loads more detail about that, but you're right, it is generally our mental health patients and those transitions, which of course is one of the aims of One Team to look at addressing. And this is data that I looked, so when I did that analysis, Sally, I looked at all of the data we've had since we started in 2021 to give because for some of these cohorts otherwise are very small, so to try and make it a bit more kind of representative and of value, I looked at it across that whole kind of 3-year period. I wondered if it was in a particular area, and also, I won't delay the discussion, but what we can do around ensuring some continuity of care. I mean, sometimes it's nurses, isn't it, who provide some sort of continuity of care in maintaining contact with patients, but I won't prolong the discussion. Thank you.
Thanks, Sally. Teresa.
Yeah, as Debbie's just mentioned, one of the areas we've been really focusing on through our One Team work is that clinical history taking, which once the patient has given their history once, any future referrals or any future contact with other teams, that information is automatically carried through to any new assessment forms and the care plan populated on the back of that. So it is really aiming to reduce that duplication and that oversight of a patient's history, to improve that sort of sense of continuity, even if there isn't the same work of.
Thank you very much.
Thanks, Teresa. Debbie, I may have missed it in the papers, but last time we discussed some of this, there was an issue about the inpatients at Prospect Park being in a sort of the right state of mind to be able to give patient feedback, and I think you and your colleagues are going to investigate other ways of understanding their concerns or otherwise. Is that do you feel sort of comfortable we've got a position that's able to take those complaint histories, if I can put it that way, from inpatients?
Yeah, so we have part of the work we're doing around the Culture of Care programme of work absolutely has patient feedback as well as staff feedback at the centre of it, and also engages with people with lived experience and recent lived experience to help with that. So what I can do for the next report is try and put in a little bit about the culture of care. There's also community meetings that are part of Prospect Park, so there are other ways, many other ways of hearing those voices from those patients.
Yeah, I think that'd be helpful if you could. Julian.
Thanks, Martin. Yeah, the other thing that's really noticeable, if you looked at the report from, say, 18 months ago, 2 years ago, is the number of MP inquiries. And I think there's two reasons for that, Martin. Since May, we've had 7 new MPs. I wrote out to all of the MPs, providing contact details, but also the process. So we have had some sort of come through, but I suspect that's partly because obviously some of them are still finding their sort of feet and navigating that and looking at key issues. A number of them have been heavily involved around the new hospital build. So certainly the ones in the West have been really focusing on the Royal Berkshire issues. And then secondly, I would say if you go back a couple of years ago, it was predominantly around children's neurodiversity weights. And we certainly haven't cracked that, but we're in a much better position in terms of kind of responding back and everything else. So I do think there's been an improvement there. And 80% of the MP queries previously were around that. Now, increasing referral rates may see that change, but it is the most noticeable trend. If you were to look at the 2 reports, say from this one and 18 months ago, 2 years ago, it's definitely the MP's thing that has changed. And I thought it was just useful to provide a bit of context behind that.
Yeah, thanks so much. Very helpful. Okay, in which case, Debbie, thank you very much. Let's move on to Quality Assurance Committee. And Sally, shall I hand over to you to take us through these?
Yes, I'll leave the Learning from Deaths report and Guardian Safe Working to Minnow. But as you will see from those minutes, we had a number of presentations, and to pick up on what Debbie referred to a few minutes ago, we had a presentation on the Culture of Care programme, which involves 3 of our wards, Sorrel, Rose and Orchid. It's a NHSE funded programme, which was in response a couple of years ago to concerns at a national level on the standards of care in adult inpatient mental health wards. And essentially for us, it brings together and integrates into some of our existing work streams around reducing restrictive interventions.
Sally, your microphone's gone off.
Oh, sorry. There's a big did you hear that on integrating into our existing work streams around restrictive practice? Yeah. But it also, there's a big focus and builds on our work on QI at ward level, organisational level. So it's quite a big project. There has a big focus on terms of staff morale, staff engagement, as well as service user engagement. So it's an interesting project. The committee was very interested in it, and we've asked for what we'd like to see, but it might be a bit difficult. It's obviously what the outcomes are going to be. So it'll come back to the Quality Assurance Committee. We also, and we've got this, I think it's in part 2, we looked at the quality impact assessment process, which we've now integrated into our financial planning process. Quality concerns we'll discuss in more depth in part 2, but what we've added to that is perinatal mental health services and also talking therapies. And again, we'll come back to that. But two more things we talked about, which are quite important. One was Martha's Rule, which were actually were the first mental health trust to integrate that or try and implement it within mental health services, which is, there's a lot of interest in that, particularly at national level. And we're also looking at how we integrate it into our community services, which is slightly more difficult because of the dispersed nature of them. And the final thing we looked at, which we'll discuss later, is the independent mental health homicide review, the Nottingham report, and the actions that we've taken in response to that, which obviously the board needs to look at, and we will subsequently do that. But if anybody would like to ask me any questions on the minutes, I'll be very helpful. I'd be very happy to respond to them.
Thank you, Sally. Any questions for Sally on the meeting? Okay, Minu, would you be able to speak to the Learning from Deaths and the Guardians of Safe Working, please?
Sure, thank you, Martin. Good morning, everyone. The Learning from Deaths report is it's a standard report. There's nothing of concern or out of the ordinary. There are no deaths which have been assessed to have a governance cause of concern or an avoidability score, as we call it, for physical health deaths of 3 or less. However, there are some instances where our care has been rated as poor in inpatient care, also in community health services, and some in mental health. And we have identified learning and disseminated that. We've done an analysis of the ethnicity, but there is nothing there which appears to raise red flags at the moment. Happy to take any questions on this report from the board.
Any questions on Learning from Deaths? I'm just I'm pleased. I know it's difficult, the ethnicity analysis with the data we've got, but I'm very pleased to see it clearly in the report. I think that's the right thing to do, and at least we've got something which will hopefully flag up concerns if they do arise, so we can start to then act as and when we see it.
Absolutely.
Otherwise, I think it's a very clear and satisfactory report. Anybody got any questions? No? Okay. Guardians of Safe Working, can you?
Thank you. That is an unremarkable report. There are only 2 exception reports from our resident doctors, brief periods of time, which were always closed by giving them time off in lieu. There is no concern that there are any systemic issues, and really 2 exception reports are. I can't find anyone which probably has lower than 2, although we don't benchmark nationally these things. At the same time, we have our guardian who spends quite some time with our resident doctors to ensure that they will do the reporting if they're required to do that, and they will not hold back. So overall, fairly satisfied that we are not reducing the reporting opportunities. At the same time, we don't have much reporting from our resident doctors.
Thank you, Manu. Any questions? It's a very reassuring set of data for the resident doctors, isn't it? I mean, the Guardians, we have a consistently good result on this, which is excellent. Thank you.
Thank you.
Okay, item 6.3, the Nottingham Independent. Sorry. Oh, Julian, sorry.
Minnie, just in terms of resident doctors, are we? Is it because we roster well, or is it because we're fully established? So do we anticipate that we're going to have, short, too few doctors at any point in sort of resident status, or have we sort of basically got the numbers right and the sort of rotoring basically right? Is that what we're doing? Because this is not the same report that's going to other organisations in terms of largely on track.
Yeah, thanks, Julian. I think that's an absolutely important point. The way we roster our resident doctors, they are mostly in for training purposes. So there are organisations which have to maintain a balance of service versus training. Given its training, the only place where there is some breach from time to time, like the 2 exception reports now and a few in the past, is in inpatient mental health, where sometimes a patient is admitted and an episode of care has to be completed. Hence, the way they are posted, rostered, is a sort of a safety mechanism that they are not entirely thrown into extremely busy environments. All of that is managed by our substantive sort of consultants and middle grade doctors. So no, I don't foresee there to be a problem in the future unless the system is significantly changed.
Okay. All right, Julian. In which case, thank you very much. Then if we could move on to 6.3, the Nottingham Independent Mental Health Homicide Review and the Trust's action plan for this very serious event. Tamina.
I think it's going to be me, Martin, if that's okay.
Teresa.
Yeah, welcome, hand over to Teresa, yes.
Welcome, Teresa.
Okay. Thank you. This paper is bringing the board's attention to the independent review that was published in February that requires trust and ICB boards to have oversight of the report and the subsequent action plans. So for context, back in the summer last year, we completed a maturity matrix which identified 14 areas of best practice, particularly for patients with complex psychosis, poor engagement with services, poor compliance with treatment. So we submitted that maturity matrix back to the ICBs in September, and then in November we were asked to submit business cases for a combination of either assertive outreach teams, which are dedicated services for patients with exact criteria, poor compliance with treatment, psychotic illness, often lots of comorbidities as well. That was submitted in November, and subsequently we've been working internally to look at the needs of those patients. So 2 strands of work sitting in this space are our internal work around that cohort and how we can improve sort of our psychosis offer and treatment and outcomes for them. But more broadly, this paper picks up the 5 key actions from the Nottingham independent inquiry. So the first area of focus was around personalised risk assessment. We've been doing significant work in that space, moving away from RAG rating, so red, amber, green, high, medium, low risk, to a much more formulation based, which is around understanding the individual and their context of their mental illness and understanding of treatment needs. So that's well in progress. There's a dedicated programme of training overseen by our nurse consultant network. The next action was around joint discharge planning. We've been working and focusing initially on our inpatient services, really making sure that discharge meetings happen well in advance of the patient leaving the ward, bringing in the right agencies to support that discharge, including family and system partners. And to enhance the work of, particularly around this cohort, is around homelessness and complex discharges. So we have some dedicated roles that are working to improve the experience and outcomes around that joint discharge planning. Our lead nurse consultant for preventing harm to others is working on our multi-agency response and working particularly well with our probation colleagues, our forensic pathway, and through our right care, right person response, our relationship with the police. So a number of formal meetings that happen looking at high risk individuals and looking at joint and shared care plans around those individuals. The next area of focus was around working with families. So our dedicated carers lead is helping shape how we recognise and support carers. But a link to the Martha's Rule is this care concern panel, so giving carers opportunity to escalate if they are worried about an individual. So starting with inpatients, but our expectation and plans is that we will roll that out through into our community teams as well as into community services. And the final area was around our reducing and eliminating out of area placements. So there's a combination of our planned out of area placements, so our partnership with Poppy Ward over at Priory, but we do at times have patients that need to go further afield, and that's normally around our psychiatric intensive care provision. So opportunities there to work within the provider collaborative to look at how we might improve the provision and availability of particularly female PICU locally. So it needs to be noted by board. There is an action plan that is under review, and that is held by the lead nurse consultant for preventing harm to others. Happy to take any other questions.
Teresa, thank you. I got just something I just wanted to raise, if I may, just it's a clarification issue. If you look at the various events of this type, not necessarily this one, you often find it's a multi-agency thing where information, was available to one party and not shared, or that there may be something which wasn't sufficiently evidence of a serious potential event happening, but when it's collated with other evidence, that it would lead you there. And so when I'm just reading the action plan, I was looking at the multi-agency one. Can you assure us that there is in the way of handling this a sort of a process that makes sure that this sharing of information actually happens? You know, the words talk about, you know, multidisciplinary teams with other partners, etc. But it's whether there's a sort of formal process so that it automatically kicks off something that has to be followed through, so you avoid the fact when it may not be carried through because somebody didn't think it's quite right. Can you just say something about? Sorry, I'm being a bit incoherent, but it's yeah. Can you help me a bit on that?
Yeah, absolutely. I think often some of the challenge, Martin, is not knowing who's involved. So part of the work we've been doing through our one team work, both in patients in crisis and in the community, is really trying to map which agencies are involved much earlier. And our nurse consultants that have particularly strong links into forensic services, into probation, are pulling together those strands of work. So a recent example was we've had somebody who has presented to Prospect Park through our place of safety, and it's sort of pulling and understanding who else has been involved. They're new to this area, but previously known by probation in Kent. So there are some much more robust processes around that sort of post admission, that 72-hour work. And then from the other end, where patients are well known, is some of our panels that we've put in place. So we have our standard trust clinical risk panel, which we invite partner agencies to contribute to. So there is a shared decision making about risk management and follow-up actions. We have some dedicated clinical time working on multi-agency care planning, particularly for patients that have frequent contact with perhaps with the police or through section 136 to place of safety. So that work is pulling those strands together. And then we have a criminal justice panel. So where if we have individuals that we're worried about risk to public and family members, perhaps to staff, that we can take those cases, and we have some detailed discussion around how best to work collectively to mitigate and manage risk. So that's sort of stuff that sits with us as providers. And then in terms of attendance at MAPA, the statutory public protection meetings, and MARAC in terms of domestic abuse, that we're making sure that we have representation at those sort of really formal meetings to feed back into teams and to make sure that we're sharing information that we hold about individuals.
Teresa, thank you very much. Very helpful. Sally.
Teresa, I know I've had an opportunity to ask questions about this, but it only occurred to me afterwards and looking at this again. There's big focus now, or not a big focus, but we're looking at the use more of Part 3 of the Mental Health Act. And what I've thought was there's been a bit of a silence on, and when I looked at our benchmark data in relation to mental health, what we don't refer to in here is whether we've considered CTOs. I know that CTOs have had a sort of bad name, particularly as there was the review of the Mental Health Act, but I wondered where we stand in relation to the CTOs, in relation to others, and whether that's being considered here, whether we're using that enough, if you like, which sounds very crude.
Yeah, I mean, I think that there are two areas, Sally, that we do need to think about how we improve access and availability for our patients. The first one is around clozapine, which is our sort of treatment for patients that have treatment-resistant psychosis. And we don't benchmark very well in terms of the percentage of patients that should be at least offered and considered for clozapine. So that's one area. I think in terms of the use of CTOs, they are a regular area of conversation for patients when we're in our MDTs. I think particularly when you look at Valdo's case and the Nottingham Review, he had lots of Section 2 admissions, and a CTO can only be applied after a Section 3. So
right.
So it's making, so if patients need to stay in hospital for longer, really thinking about the use of Section 3, known patients coming in on a Section 3 rather than a Section 2. So there is work in that area, and I'll reflect that into the action plan.
Right, and that might lead, Section 3 then might lead on to more CTOs. Yeah. Thank you.
Okay, thank you. Julian.
Thanks, Martin. It's a follow-on from your point, but I guess sometimes the way you described it is a bit of a catch-all, isn't it? So agencies sharing information. If you look at this and other cases, including ones where things have gone wrong for us, but not in quite the same way as the Nottingham case, sometimes it's not just about sharing information, it's agreeing multi-agency what to do with that shared information as well. And I think there are occasions when mental health services don't escalate enough. Now, we've got a really good relationship with Thames Valley Police, but inevitably, officers on the street will make judgment calls. So we now know, don't we, with the benefit of hindsight, that Nottinghamshire Police didn't arrest Aldo on a number of occasions after committing violent acts because of sort of mental health issues. We'd be really clear that when serious violence happens, an arrest should take place, and the courts can decide, whether it should be a criminal element of the Mental Health Act or whatever. And that clarity still doesn't exist universally, I would suggest, in mental health services, criminal justice services. And one of the things that we need to do, as well as thinking about our service provision, is when things are deteriorating, the level of forcefulness, assertiveness and clarity around, when information comes to light, what we expect to happen. So for mental health services, Sally's quite rightly put up about the issue of being really clear about the usefulness of CTOs, community treatment orders, where people are reluctant to accept treatment and don't have insight into illness. But when people do commit serious offences, that people are sort of not brought back in for informal admission or into 136 suite, and that very serious act of violence doesn't translate into a criminal conviction. And that's absolutely key, and goes right back to the days of sort of the seminal findings around Christopher Clunas 25, 30 years ago. So not only information sharing, but absolute clarity about who will act on that key bit of information. I would say with these cases, it's also key. And I think it's an area we need to think about. So we talked about Martha's Law, didn't we, where people can ask for a second opinion. On cases like this, where it's complicated, almost we should have an internal second opinion. Do you see what I mean? Where people are actually looking and saying, actually, are we getting this judgment right about this case? And again, I think that would really strengthen our position, because these are not easy decisions for individual clinicians to make.
Thank you, Julian. Mark.
Yeah, thank you, Martin. I just wanted to pick up the point that Sally made earlier in terms of the use of CTOs. Just anecdotally to reassure her that on the mental health appeal panels that I used to sit on, I was always reassured by the responsible clinicians that were looking for the least restrictive option for patients and their use of CTOs, and that this was seen as an extension and an option in terms of people coming out from Section 3s and that environment. So I'm certainly convinced that that is something that's actively being used and considered by those responsible clinicians.
Thank you.
Thank you very much, Mark. Teresa, we've had a very comprehensive set of data, a paper from you and the presentation. Is the board content that we're happy with the plans? Okay, in which case,
Martin,
sorry?
Martin, can I just ask, yes, at this moment in time, but it would be useful, I think, for the full board to check on progress. I just wondered whether we could set a date for that. So I think in addition to the quality committee, given the seriousness of this, and also the fact that these are cases where we know we can have an impact. They are treatable cases, so it really is kind of our bread and butter. I just wonder, well, when we think a sensible date, just be reviewing progress on this, so we don't let it slip from our priority list.
Do you have a suggestion?
I'm looking to Teresa really to give us a sense around what's not too soon, but I don't want to leave it too long either.
Yeah, maybe September, Julian. So we've got these will be published on the ICB boards in June, so they will be kept under regular review. So maybe September time would be a good opportunity to bring it back.
I'm going to seem a sensible amount of time to continue to make progress, demonstrate progress against some of these actions. So I'll be happy with that, Martin. We can pencil that in, Julie, please, if that's okay.
That's fine. Let's do that. Okay. Thank you very much, Teresa. Just follow the next agenda. Executive report. Julian, just questions as normal, or did you want to raise anything?
Yeah, a couple of things, if possible, please, Martin. Yeah. I'll leave it to you at the end just to talk about Minu and Tamina, because you know, it'll be the last sort of blow. So let's put that towards the end. Item 6. Obviously, it was written in a moment in time in terms of changes at NHS England. That has accelerated quite markedly now. So Wes Streeting has announced a 50% reduction yesterday in headcount at Departments of Health and NHS England, with a view to sort of bring it under much closer government control. We've seen resignations from the Director of Finance at NHS England who go at the end of the month, Chief Operating Officer, Chief Delivery Officer, and probably others too. I believe it's around 7,000 roles between the two organisations will be disappearing. So we are seeing the biggest changes since the Andrew Lansley reforms sort of came about. The pace of this was slightly unexpected. It's happening at some pace. It's in line, I guess, with what we've heard around the wider Whitehall reforms, Martin, but also to some extent around Secretary of State's concerns around two parallel organisations operating in this, and a desire to bring things closer to sort of government and make sure everybody's working on those priorities. So I think there'll be more in this space, but pretty seismic changes happening, I would say, in relation to that. What I wouldn't want it to do is overshadow as well just the local authority devolution. I've included some slides in the part 2 because they're from the Berkshire local authorities. I'm not sure yet if they're in the public domain. And I think it would be quite useful to have a conversation in part 2 around what's going on for local authorities, because it does also tie in potentially with what's going on in health as well. So perhaps a conversation for part 2 for that one, if we can, about what I think is going on there on the back of that those slides. But as you can see, in terms of what's in the public domain, quite a bit going on local authority change as well. So local authorities, social care, massive changes at the moment. No surprise, perhaps, but.
Brilliant, thank you. I think we'll have a chance to talk about those in part 2, and also perhaps some of the NHS changes. We do have to formally approve the modern day slavery statement, which is in your report. I think this is not contentious, so I hope that people are happy with that. Anything else on Julian's report? Okay, we'll pick up the other things for discussion in the private meeting. Paul, month 10, finance.
Yeah, thanks, Martin. So I'll take the report as read and just highlight a few key points. As you see from the report, we remain in a stable position in the sense that we're on plan for the year to date, and we're on plan to deliver our agreed revised forecast of 4.9 million by the end of March. Saw increases in January in terms of both substantive and temporary workforce numbers, and costs increased marginally above plan by about 100,000, but we're still containing overall paid costs within year-to-date allocation. So we're 800,000 underspent on pay year-to-date. We're still operating below NHSE's agency ceiling, and if you look at use of framework arrangements and price cap breaches, we're continuing to see downward trajectory on both of those, and clear controls in place in terms of approvals. PQ placements were higher than planned, and we saw an increase of 8 in January, rising to 29. So that's probably the single biggest pressure on the non-pay position, but again, it's been contained within our overall forecast numbers. I think, as was mentioned earlier, Poppy Award did open beginning of January, but we're still transitioning to opening its full capacity, so not all of the beds were available during the January period. Elective recovery, we're now ahead of baseline activity targets for both ICBs, only just ahead for Frimley, but obviously well ahead for Bob in terms of where we expect it to be. NHSC have introduced a financial ceiling on the level of elective recovery activity that systems can pay for this year, but we've agreed a position with Bob ICB in line with our forecast, so we don't have any risk on that ceiling adversely impacting our forecast of 4.9. Cash is higher than planned, so we're at 53.9 million, but that's partly driven by slippage on the capital programme. So with the capital programme spending in line with expectation, by the end of the year, we'll expect to see those cash balances reduce, and we'll probably finish the year somewhere in the region of 46 million. Happy to leave there and take any questions, Martin.
Thanks so much, Paul. Any questions? I must say it looks a very well-controlled process. The Trust is doing well, I think, in managing all this in difficult circumstances, and we'll be talking in part 2 about next year onwards, which perhaps is more challenging. But thank you very much, Paul, and thanks to your team. Okay, can we do the performance report then, please?
Yeah, thank you very much. I will take it as read, and there's a 2 or 3 pages just to kind of summarise some of the main areas. I suppose a couple of things I just wanted to emphasise, picking up on Paul's point, the fact that sort of despite some in-year challenges as well, we're continuing to deliver against the control total, which I think, especially given the backdrop and the context of some of our partners, continues to be a really impressive position for us. There's a couple of areas where we know we need to do some development. So one area of that being perinatal, and I know it's one of the areas that Teresa wants to pick up on when she takes over as the coup, but we are looking at an improvement programme around that. I flag it just because it's something that Bob had flagged a couple of times in our tripartite meetings as well, just to make sure that we're getting the accessibility available across all of the 6 areas that we provide a service, and that we get the uptake that young pregnant women need. So that's an area of focus for us. And then I suppose I just wanted to flag this time of year when we're looking at some of the data around our occupancy rates. We set an occupancy rate that's kind of allows us to create some sort of safe management and flow of patients, which is absolutely right. But I think we do need to just remember the context, particularly when I'm thinking about our community beds. So yesterday I had a call, for example, from the medical director in RBH saying that they came into 36 patients with a decision to admit. So, and we have 14 beds free. So of course they're going to want to fill all of those beds. So there is a constant sort of dynamic that our staff are managing around that. So making sure that we try and stitch an occupancy rate that feels right in terms of the guidelines and the guidance, but recognising some of the pressure on our patients. And you'll be aware as well in terms of the mental health beds, the sheer kind of demand that we have and the acuity of patients, managing the dynamic again in terms of the occupancy rates we have in PPH. We're also trying to minimise the number of out-of-area placements we have as well. So I just wanted to kind of remind board members of that. Apart from that, I think other areas have been picked up on. For example, Debbie mentioned around I Want Great Care. So there's nothing else I particularly wanted to flag, but any questions would be welcome.
Thank you, Tarina. Any questions, please? Sally.
Tamina, you're aware that at the Quality Assurance Committee, we looked at the audit around Rapid Trank, and I know it's difficult to pick out here, but it does look as though we've got around restrictive practice, we've got a sort of continuation of red, haven't we? And I don't know whether you'd want to say anything around that, whether it's, I know sometimes it can be very affected by individual patients, but we do seem to have a sort of trend there almost, don't we? And because we just recently, when I read these papers, I just recently chaired the Quality Assurance Committee, and we looked at that audit. I wondered, you know, whether that's a sort of an issue. Well, it is an issue for us, isn't it?
I'll ask Teresa to come in a moment, so I've just put you on the spot there, Teresa. And I suppose there's something about the narrative there about the number of patients who contribute to this, and certainly sort of a balance where staff would determine that rapid tranquilization was required, but also there are some examples there where patients have asked that to support them in managing particularly around sort of self-harming behaviour. I have put you on the spot there, Teresa. I don't know if there's anything more you want to say around that.
Happy to answer that, Sally. So we are doing some work with our partners in Oxfordshire, Bucks and in Surrey and Borders. What we are counting as rapid tranq and our restrictive interventions, there's not parity across the space. So we are including patients requesting PRM medication in our data. So as part of our refresh of our breakthrough objective for April, is we're looking at particular aspects of restrictive intervention. So the team are just working through with the QI team to pull together the parameters around the most restrictive interventions, and really we're going to have a focus on that rather than see it as in the round.
Right, no, that's really helpful. Martin, may I ask another question? It's around, and I think this is my fault, and I should have picked this up. Debbie, I didn't realise, and I know we get the report regularly. Perhaps I didn't join up the dots. That actually we've had 4 incidents of C. difficile, and I just wanted to ask. They were 4 separate incidents, weren't they? Because that's unusual for us to get 4 incidents of C. difficile. Is that, in terms of ones when you look at the performance card?
It's not. C. diff has nationally. There's been an increase in this being picked up. It's not unusual, Sally, so it's not something.
It's not a concern.
No, it's something we keep an eye on, and of course we want to ensure that we're doing appropriate antibiotic prescribing and ensuring that we are doing everything we can to prevent C. diff. There's always a national focus on that, but I'm not concerned around.
Right. It's just when I looked at the performance card and it looked unusual to me, and I just wanted whether that was a sort of something we should be concerned about, or whether you felt it was just a sort of natural variation and we had the necessary controls in.
Yeah, no, we haven't. So we look at every single case and we look at whether we think there was anything that contributed, any lapse in care, if you like, and we have not found any to be anything significantly we could or should have done differently to mitigate those.
Right, thank you very much.
Thank you, Sally. Anything else? Okay, so we'll move on to the Finance, Investment and Performance Committee. Naomi, anything you wanted to raise?
Very brief. Martin, there's nothing really that we discussed back in January that the board isn't already across, and we will be looking in some detail in part 2 at the plan for 2025-26. So that, like I said, very brief, but I'm happy to take questions.
Well, we'll have a chance later on to get into some interesting discussion. Okay, let's go on to the annual Green Plan report. Paul.
Yeah, so this is annual update that we required to make to the board to update on all things in relation to sustainability, and in particular how we're progressing against our Green Plan. This is the final year of our current Green Plan. Over the next year, we'll be developing the next iteration. So we've got Justine and Ailsa with us to go through it. Justine's just returned back from maternity leave, and Ailsa has been capably covering the post for the past year. So happy to hand over then to take the board through the presentation.
Thanks so much. Welcome.
Thank you.
Thank you very much.
Hopefully you can see our presentation. Just check that before we move on. Great. Thank you. I'll hand over to Justine.
Great. Thanks, Ailsa. If we could go on to the first slide, great. Hi everyone. Yes, so just a quick recap on our both moral and legal obligations to act on the climate emergency. So both the UK and the NHS have enshrined net zero into law, but we have slightly different targets. The NHS is committed to net zero for its direct emissions by 2040. The UK is 2050. And beyond the law, there is obviously the irrefutable human case. So we know that reducing emissions reduces admissions. So we know that living in cleaner environments helps to lead to a lower care burden, fewer cases of certain diseases. So for instance, we know that breathing in dirty air reduces your life expectancy, can cause things like asthma, heart disease, lung cancer, even diabetes. And recently there was a systematic review, which I have noted at the bottom there, if you're interested in having another look, which looked at climate policies, addressing things like air quality and physical activity and dietary changes towards more sustainable diets, led to a reduction in death of around 1.5%. So I've left the reference there for you as well. And it's also it's more than just getting a slap on the wrist if we don't meet our climate obligations. We are seeing increasing numbers of lawsuits against both governments and organisations for not meeting their climate obligations and goals. Next slide, please. So what do we need to do about it? We have both contractual and legal obligations to act on net zero. So some of these goals are outlined in the NHS standard contract. So there are lots of things that we need to do, but with both a limited time and limited budget, we really need to focus our efforts on the big ticket items, the big wins, like getting rid of gas in our estate, also focusing on transport, which is a big source of our emissions, and also focusing on our larger sites, our priority sites, such as our hospitals. We have had a very comprehensive energy surveys, decarbonisation plans conducted our priority sites that we manage. And these basically found that, unfortunately, because there has been a change in the public sector funding guidelines, eligibility, only 2 of our sites are actually eligible for funding to decarbonise them now. So you may remember that we won £2.6 million from the government to decarbonise West Berkshire Community Hospital. That project is underway, but only 2 of our sites are eligible for future rounds, which is Prospect Park Hospital and Abel Gardens. So we really do need to try and capitalise on those. So just to give you an idea, these decarbonisation reports found that it would cost over £12 million to decarbonise all of the buildings that it looked at, and Prospect Park alone would cost £7 million. So there's obviously a huge interest in us pursuing public sector funding to get the majority of that work funded. Next slide, and then I think I'm handing over to Elsa.
Thanks, Justine. Just a quick look at our reducing emissions and progress. So overall, we have reduced our carbon intensity since our baseline year of 2018-19. Between 22 and 23 and 23-24, we have seen a small year-on-year rise in our emissions. There are small increases across all the 3 scopes. We're expecting to see a decrease in our yearly emissions from our full reporting year for this year, based on installation and activities. Our air source heat pumps will save a number of tonnes, in 300 tonnes per annum, and our solar array will save somewhere in the region of 116 tonnes. Just moving on.
Just a very quick one, if I might just add, Elsa, unless you were going to highlight on this slide, if you are, I apologise. It might just be worth noting that we separate out our emissions for total emissions for all of our buildings, those coming directly from BHFT and those from NHS Property Services buildings as well. And so while there was an overall rise the last financial year, our emissions slightly decreased, whereas Property Services went up a little bit.
Thanks, Justine. Slide 5 is demonstrating our carbon footprint. Since our baseline year, transport mileage and emissions have reduced by 628 tonnes of carbon, with 950,000 miles reduced. We can see that 38% of Berkshire Healthcare's carbon footprint is our gas usage and consumption, 26% is our electricity usage, 18% is transport scope 3, which is in effect our staff mileage, 2% is waste, and 1% is business transport scope 1. Thank you. I'll hand you back.
So here is just some highlights from the things that we have been up to over the last year. At the beginning of this previous financial year, this financial year, we installed solar panels at 2 of our sites, Early House and Churchill House. They have already saved over 14.5 tonnes of carbon dioxide, which is equivalent to planting almost 1,000 trees. And we've also got 3 further sites that are now being looked at, London House, Abel Gardens and Early Road as well. We also previously conducted a feasibility study looking at the installation of a major solar farm at West Berkshire on the land that we own there, and that is now progressing to a project initiation document as well. So we've now started our decarbonisation project at West Berkshire as well, using 2.6 million awarded by the government to get rid of gas in that hospital, which will save around 300 tonnes of carbon a year. And we also completed comprehensive decarbonisation plans and energy audits at all of our priority BHFT sites as well, which will guide both our net zero planning and also our expenditure over the coming years. We are working to reduce our utility consumption. So LED lighting has now been installed at all of our sites. We're also looking to roll out smart meters, which will help to improve our monitoring. We also installed some trial water saving loos, which saved 31,000 litres of water in only a 2-month trial period. That said, our energy consumption has actually been rising over the years now. It dropped during COVID, obviously, and it may well be that more and more staff are returning to work in the office, and we know that we have increased our footprint, but when we take that into account, there is still a slight increase in electricity consumption, so we need to have a look at that, and also use the decarbonisation plans to look at where we can make some wins there. So for instance, by upgrading building fabric, so we need to use less heating and things like that. We've also contributed to the new upcoming estate strategy, having developed a sustainable estate strategy, and we'll look to implement that as well once the wider strategy is rolled out. Next slide, please. Ailsa, you're on mute, sorry.
This is just a basic representation of some of the figures that Justine has just given us, basically looking at our electricity and gas consumption, which has risen over the years with a bit of an anomaly in 21, 22. These are figures that you will have seen in the past. However, looking at the past 3 years data, Berkshire Healthcare have decreased their consumption in gas, and unfortunately property services have increased their consumption in gas. And again, the same demonstration with 21-22 increase in water, which was significant, and a similar trend for the past 2 financial years. Just hand you back.
So looking at travel and transport, this is a big priority area for us. We do around 2.5 million business miles every year, and that's not even looking at commuter travel and patient travel as well. So it really is a big ticket item for us. It's a huge chunk of our carbon emissions and expenses as well. So we know that the NHS has recently come out with its new net zero travel and transport strategy, which Trust needs to follow. There's obviously a heavy focus on electrification there, so we need to be putting our efforts into also following that direction. We have been rolled out an electric charging network across our sites, which we will be increasing in the coming years as well. We already have 34 spots across 8 sites. We need to look at also investing in more rapid chargers. We only have 1 rapid charger at the moment. And all of our estates fleet vehicles are now electric, which could lead to an approximate 5% reduction in our carbon emissions from travel and transport, which is positive. We also commissioned a very thorough travel and transport review with the Energy Saving Trust, which is now underpinning the development of a new travel and transport strategy, which sets out our roadmap to achieving net zero tailpipe emissions. And we've also developed a clean air plan, which has recently been approved as well. So focusing on reducing emissions around our sites and therefore improving air quality and bringing associated health benefits. As we mentioned earlier, we have been driving fewer miles compared to our baseline, but it slightly increased alongside our utilities consumption. Everything went up a little bit last year, so we need to keep an eye on that as well and start to focus on implementing the recommendations from the travel strategy. Oh, we've gone back to the beginning. Oh. You're on mute. We're on the first slide. If we could go back to where we were, Elsa. Apologies for the technical glitch. Yes. Oh. A bit further back, I think. Or I think there was one before that too. Waste. Yes, here we go. Thank you.
Sorry, it's very jumping.
Thank you. Both removal and the incineration of waste comes with environmental impacts. So burning waste results in emissions. So we know that this is an area that we need to tackle as well. And we know that some waste streams have a higher carbon footprint, high temperature incineration. So we need to really focus on improving proper segregation of waste, therefore educating staff. And this is something that came up in our very recent waste audit that was completed this year. And the associated waste strategy that has now been developed off of the back of that as well needs to be implemented. We have introduced some reusable schemes, so looking at replacing single-use items such as the tourniquet, the Daisy Grip tourniquet. A trial was completed this year, and it found that implementation would save around £11,000 a year and about a tonne of landfill waste as well. Insulin pen recycling has also been implemented by the pharmacy and diabetes teams as well. So overall, general waste has been decreasing, but we know that we need to increase the rate that our general waste is also decreasing and improve recycling rates. Confidential waste has always remained high at our trust. So that's also something that we need to work on as well, because confidential waste has a higher footprint than just recycling. Next slide, please. People. Yes, we know that we can't, the sustainability team can't get to net zero on its own. We really need to bring everybody on board. Sustainability is everybody's responsibility. So cutting carbon in the workforce and also engaging the workforce. We've got a network of net zero heroes. We now have 33 of those across 14 sites. The members meet every month and look at different issues. We have a calendar looking at things like food and active travel. And generally they work together to produce some communications that go out in the Green newsletter and go out on Team Brief and Nexus and things like that to help drive momentum across the workforce. Our Green newsletter is sent quarterly, and it actually has a higher open rate than Team Brief, which is very positive. And the top article that's been produced so far is on sustainable food, so that indicates what staff are interested in. We've also been increasing our training offering, and 46 have been now trained to become carbon literate, and we are now starting to develop waste training for staff as well. Next slide, please. on our estate. We have also been investing in nature and biodiversity. Last year, we planted 65 trees at 3 sites. We installed wellbeing and nature gardens. Previously at Wokingham Hospital. Also, a new one was installed this year in Churchill House, which was opened in May. We've had some really good feedback from that, staff actually taking meetings in the summer in the pergola, so encouraging staff to get outside, which obviously brings associated benefits to their well-being. And we're also now investing in wildlife boxes at both Abel Gardens and Whitley clinics. We also developed a sustainability checklist for new properties, which is now being applied during the assessment of potential new buildings when we grow or change our estate. We have an impact assessment also that's being used by the estates team for all new capital projects. And as part of the works at West Berkshire Community Hospital, we are doing a pilot biodiversity survey as well, which will underpin the development of a biodiversity strategy. So we know that investing in nature and the green environment brings co-benefits for health. So, for instance, trees can reduce air pollution, they can reduce noise pollution, and they can reduce the risks of flooding, etc. Next slide, please. So, Ailsa, are you taking this one or? Oh, sorry, you're on mute.
Yep, can do. Okay, actions for 25 and 26. We're in the process of developing our new iteration of the Green Plan, aligned with the national and statutory guidance, and there are some workshops imminent with NHS England, and we're working obviously with the ICS and ICBs to mirror their plans as well. We are to implement a sustainability estate strategy, which will be based on the return of the information regarding the estates and facilities overall strategy. A continuation and recommendations from our decarbonisation plans and audits are there effectively on how we can reduce our consumption costs and emissions. So we'll be analysing and implementing our HDP plans in the future, along with our estate strategy. And we have engaged a new waste contractor, and we're working with them closely to implement now our waste strategy, reduce our production and our carbon emissions. One of the actions that we will be focusing on is engaging and educating our staff on energy saving and some energy saving initiatives in the future, and developing our sustainable travel and transport strategy, which is imminent. We hope to have that ready for approval towards the end of March, which will look at a number of different ways of reducing our transport mileage, which is quite complex. We will be investigating opportunities for our solar panel installations, and importantly pursuing and keeping a very close eye on the available funding nationally through PSDS and the NHS energy efficiency funding. And we will be looking to develop and implement a biodiversity strategy. So those are some of the things that we're planning to focus on in the next coming year. And that's the end of our presentation. So thanks very much for everybody's engagement. And does anybody have any questions for us? I'll stop sharing.
Thank you very much. Just wait for you to stop sharing. Thank you. Thank you very much, both of you. And Mark.
Yeah, Ailsa and Justine, thanks ever so much for the presentation. It's a really useful roundup in terms of a wide number of different initiatives, etc., that we're taking as an organisation. The one part that I didn't see within there, and it's a general question really, is how closely aligned are we as an organisation in terms of those green ambitions that you just touched on and our digital strategy? Because we often talk about our digital strategy in terms of care pathways and delivering patient experience in a different manner. But I noticed a number of different opportunities, whether it's confidential waste, for example, is increasing still for us as an organisation, that I'd hope as an organisation we could converge the two and find our digital delivery is reducing that. How closely are the two aligned?
That's a very good question. And actually this, one of the areas of focus for our new green plan is going to be digital transformation. So that actually comes down from NHS England's guidance. And so while in previous years there hasn't been that much alignment between the two areas, it's always been mentioned that we do need to focus on shifting, shifting where we can appointments to being online and reducing patient mileage and staff mileage as well. And so Ailsa, I believe, has already been in touch with Guy Northover, is that?
Yes.
Yes.
Yeah.
Yes, to initiate conversations on how we can come up with some shared objectives that work for both teams for our new green strategy this year.
Great, thank you.
Thank you, Alex.
Yeah, great question, Mark. Thank you. And Mark Davison, our CIO, also has some really good ideas around how we really become paper-free versus paper-like. We have technology like digital appointment correspondence, where we could really push on and impact the waste and paper agenda, for example. So yeah, alignment growing.
Thank you.
Thank you.
Thanks, Alex.
Thanks, Alex. Julian.
Thanks, great presentation. Thank you. If say resources were, money was sort of no object, and clearly it is, what would it be? What would we be doing that we're not sort of currently doing? Because obviously there are a number of constraints. I'm just interested in the sense that, if we had more latitude, what's the obvious thing? Is there sort of obvious stuff that we're not doing, or is it kind of we just do more at the same quicker?
It's a bit of a mix. Sorry, Ailsa, do you want to carry on?
No, it's fine. I think we've got two major strands that we could concentrate on. One is to decarbonise. We've got a reliance on gas, particularly in one of our sites, which is Prospect Park, which is heavily reliant on gas use, disproportionately so, and also our staff mileage is one that's going to present quite a complex. It's going to need a number of initiatives, a number of actions to reduce that down. There isn't a catch-all wave a magic wand and reduce it, because people are quite rightly, they've already paid for their cars and they want to use them, and to get people into public transport and active travelling is a really big ask. So I think it would be a number of small things that will collectively work, but those are our two big key ticket items. Justine, is there anything you want to add in there?
Yeah, no, I completely agree. We need to get rid of gas as a big priority for us, and that is legislation as well coming up, new gas boilers in the 2030s, and it's a huge source of emissions. Invest more in renewable energy, so solar panels ideally on every site that we're on as well, which does actually bring back payback opportunities. And yes, travel and transport is a huge source of our emissions, and it's going to be a very complex one, because we can't just change the nature of the services that we do. It's not always going to be possible that staff use public transport to get to patients, but there are ways that we can make improvements. So for instance, having electric pool cars, electric bikes in some areas. Obviously staff aren't going to go from Newbury to Slough on an electric bike, but there are some routes that do work that have been outlined by our travel and transport review. So those are sort of the big ticket items, I would say, is renewables and transport, like Ailsa said.
Thanks, it's really helpful just to have a sense about where it might go and if there's further opportunities. Thank you very much.
Naomi.
Thank you, ladies. Really good presentation, and always you bring an energy to this topic, which is really gratifying. One of the things I wanted to inquire with you about is around reporting. In the commercial world, the heavy lifting that goes around reporting is just becoming increasingly intense. And you know, you can imagine that requires resources and technologies in order to ensure that the reporting is accurate, it's timely. You know, commercial organizations are thoroughly under the pump to demonstrate, you know, that they are compliant and so on and so forth. Of course, we live in a slightly different world in the NHS, but I'm just interested in what this looks and feels like for you, Justine. You know, how much pressure are you guys under to deliver high levels of high standards of reporting across all elements of this topic, presumably through into NHS England? And do you see that as onerous and becoming increasingly so, or is it really quite manageable?
Excellent question, and absolutely, it is a serious earache. We have so many different sites, we have so many different streams of data. We need to rely on property services giving us timely data. We need to rely on the PFIs giving us timely data. We need to integrate all of these different streams of data. Often they come, some of them come in monthly, some of them come in quarterly. We have different waste contractors. At the moment, we're managing the transition from one waste contractor to another, and neither of them know who's supposed to be giving us their data. All of these things like that make it a very complex and onerous task to actually report on our carbon. But actually, this is I don't want to say that this is a burden we place on ourselves, because NHS England actually don't demand that we, submit how we do all of our calculations, because they know that all trusts do it differently. Even though we follow the best practice in the greenhouse gas protocol, they know that this is an area that many trusts don't have the expertise on. Some of them do outsource it, some of them do it in-house. People do their calculations in different ways. We worked last year to improve on our carbon reporting and refine it. So we are actually not obliged by NHS England to disclose what we do, but we do anyway, so for transparency. And it is something that we could consider outsourcing, but it's very expensive, and it wouldn't necessarily bring a carbon return, but it would save a lot of people time, because it is a big task, data management at this trust, because we naturally have such a fragmented estate. Yeah. Supply chain emissions is something really big that we haven't actually looked at before, and this is very much where we do need to bring in an extra pair of hands, but more likely in terms of bringing in software rather than bringing in a person, because going through line by line all of our expenditure and working out the carbon emissions would just be a phenomenal amount of time, whereas there are artificial intelligence platforms that can come in, take your spreadsheets, work out the carbon emissions, work out the spends, and then chuck you out a report and say these are the areas that you could work on. So that's something that we're looking at next year as well.
That's super helpful, Justine. And if I was a betting person, I would say, you know, putting us into a place where we are ready, willing and able to do substantial and credible reporting, it is invaluable, because I just feel that in this fullness of time, whilst there isn't a current obligation to submit detailed reports, you know, on a timely basis when that is going to come.
Mm-hmm. Yeah.
Okay. Thank you very much, Justine. Thank you very much indeed for the presentation. Important topic, and we'll come back to it. Is it it's an annual report we have on this?
Yes.
It's an annual report, and we'll be bringing the new green plan, I can imagine, round about middle of next financial year as well, for board approval.
Okay, thank you. Thank you very much, Paul, too, for that.
Thank you.
Bye.
Bye. Okay, item 10, Councillor Governor's update. Just a couple of things. One is that I think the quality meetings the governors have are very active, very seriously taken by governments, which is good news. And of course, the other thing is the appointment of the new NED in place of Naomi, and that's Julie and I have been having regular discussions with the recruitment consultants and the appointments committee of governors will be considering long listing very shortly. So that's all moving positively forwards. Rajiv, audit committee, anything you wanted to raise particularly?
Yeah, this is the January Audit Committee report. The only thing I'd say is one of the agenda items this time around was the annual review of the cybersecurity report, and I think everyone in the Audit Committee felt that we're seeing good progress and good status on that, but happy to take any questions.
Thanks so much, Rajiv. Any questions? No? Okay, thank you very much. Use of the trust seal, Paul?
Yeah, reports in there, just confirmation we attached the seal to the deed of variation to enable us to build the new place of safety at Prospect Park.
Okay. Thank you very much. Any other business? Well, I have a piece of any other business, of course, which is to recognise we're going to be losing two of our very highly respected members of the board, Tamina and Minu. Tamina has only been with us, I think, about 3 years, Tamina, isn't it, about that, from Oxford Healthcare, and is now obviously looking to distance herself from us as much as possible by going to North Wales. I think she's going to be climbing mountains and all the rest of the things you do in North Wales. I was going to try and learn a little bit of Welsh, but it's quite beyond me, and I couldn't find anything on the internet that would tell me how to pronounce the things I wanted to say anyway, so I'm afraid I chickened out. So I think we all on the board really valued your contribution over the 3 years. You've done great work as the coup, taking things forward, the one team, etc. So thank you very much sincerely for that. I know we wish you all the very best in the future, and hopefully we'll see you back in England sometime before too long. But thank you very much, Tamina.
Jochen Martin.
Oh, don't show me up even more. And Minu has been with us a long time. I don't even know how long. All I know is that as long as I've been here, Minu's been the medical director, I think. And Minu is a man of great depth of thought. And it's one of those things that, as a layperson, you know, I ask Minu sort of silly questions, and rather be told it's a silly question, Minu always has been polite and kind to me and answered the question, and also really got beneath the surface of issues, which I very much valued. He's very highly respected by his colleagues. He's a great leader of the medical teams and a great contributor to the board. So Minu, just our very best wishes and thanks to you. You're not entirely leaving us going to Wales, are you? You're non-exec now at the Royal Berks, which is excellent in terms of building the relationships. So I know the board will be in contact and being visible. You'll be visible to us in the future. So thank you very much indeed, sincerely. It's a great job you've done at the Berkshire Healthcare. And a lot of the progress we've made over these years has been down to your leadership. So thank you very much for that. Well, rather sad everyone's going, but anyway, thank you for both of you. Good luck. The date of the next public board meeting is the 13th of May 2025. Well, 2 days after my birthday. Another year gone. So with that, we'll have a break and consider our normal resolution to exclude press and the public in the remainder of the meeting. How long do people want to have? 20 minutes break? I always look to Julian because